series of videos, we are going to be looking at the reasons why certain answers are the correct answers, and also we are going to be having clues towards some questions. So peradventure questions have changed due to one reason or the other, we'll still be able to figure out the right answers by the grace of God. For example, this is the Krok 2 internal medicine folder 2014 base, and this is the very first question. So we have a 47-year-old woman that complained of paroxysmal headache for the last 5 years. So what are the remarkable signs in this particular patient? One-sided headache, and it is preceded by nausea, stomach discomfort, and that is referred to as aura, A-U-R-A, and aura together with this arterial blood pressure of 170, which is elevated. Also notice that neurological state of the patient is irremarkable. So that excludes the first, fourth and the fifth option. So we have migraine and epilepsy because they are usually preceded by aura. So since it's one-sided with elevated blood pressure of 170 without neurological states being remarkable, so migraine fits best in this particular question. So wherever we see it, you see a patient that is having one-sided headache, elevated blood pressure, aura is present, and neurological state is not very remarkable. So think of migraine. Second question is a 7-year-old boy, and they are telling us that if you read through the question, it's called that the patient is having a spontaneous bleeding, not triggered by trauma. So what is peculiar in this particular patient is family anamnesis of hemophilia is absent. So that does not mean it's still not going to be hemophilia, because hemophilia is X-linked recessive disorder. So it's only a patient that is, if it's female, is going to be homozygous before they can manifest the symptoms, and if it's a male, just a male. So this usually manifests more in males. So for this particular patient, they are telling us that clotting factor 8, which is hemophilia A, which, like this factor we are supposed to expect to see hemophilia A, is about 5% of norm. So 1 to 5% of norm is like a moderate severity form of hemophilia, and that is why this patient is having spontaneous bleeding. Also, when you have increased thromboplastin time, you can see increased thromboplastin time of 72 seconds. You think of about 3 basic diseases, although there are more. You think of hemophilia, you think of DIC, and you think of von Willebrand disease. So in this particular patient, we'll go for hemophilia A, saying that it is 5%. So you have history of spontaneous bleeding together with it. They made it so easy by giving us this particular information. So we have hemophilia A. Okay, we need to pay close attention to this particular question. A patient is having chest pain that is reduced by bending forward and dyspnea, and that, I believe, is typical for pericarditis. But they said the patient had, like 3 days prior to that time, acute anterior myocardial infarction. Ordinarily, together with the ECG signs, ordinarily in a normal international question, the correct answer is Dressler's syndrome. Dressler's syndrome is post-myocardial infarction pericarditis. But for Krok, they decided that the answer is acute pericarditis. I cannot really justify their answer for them. I believe it's Dressler's syndrome for the sake of our exam. Is acute pericarditis. So here's our next question. We have a 54-year-old man here who is having headache in the hospital region and vomiting at the same time. Notice the blood pressure is 230, 130, and you would also notice intense headache together with increased muscle tone and reflexes. tension of neck muscles, photophobia. These are meningism. Notice I didn't say meningitis, I said meningism. So meningism, you can have signs of meningitis but yet not of infectious origin. So that, together with the blood pressure that is low, that excludes bacterial meningitis already. Disseminated sclerosis, there's nothing pointing to it in this particular question. Myasthenia gravis, there's going to be muscle weakness, but according to the history of this patient, not myasthenia. And migraine will not really present with this meningism. So our best shot in this particular case, based on diagnosis of exclusion, is acute subdural hematoma. So that would really help us. So a 51-year-old woman was taken to the emergency department in convulsive status epilepticus. In status epilepticus, you just know that you cannot give the usual treatment of a patient that have epilepsy. So the very first thing that you are thinking about is that these patients need to be breathing properly. So it's so simple. Just ensure that airway is open and patient is oxygenated. Next, we have this particular question. After reading through the question, you will discover that the patient feels intense pain behind the sternum, especially after utterance. Although in this particular question, this is misleading because we have it in a lot of cases. However, the X-ray picture of the thorax organ presents esophageal dilation, and that is very common to esophageal achalasia. There is narrowing of the lower esophageal sphincter, causing the esophagus to dilate. So patient is going to have difficulty like dysphagia in passing down both solid and liquid substances. So in this particular patient, and they said the patient has not put off weight. If patient is putting off weight, you think of cancer, but in this particular case there is no cancer. And another condition that will have actually distracted us is esophageal spasm, but there is no diffuse esophageal spasm here because they will tell us that probably the maybe after intake or whatever, but the patient is not going to have dilation of the esophagus. It's called Krok on X-ray for esophageal spasm. So the best answer here is esophageal achalasia because the esophagus is dilated with level of fluid in it. Okay, we have a 35-year-old woman presenting like any other thing that you can actually think of with respect to the colon. But what is peculiar about this particular case is colonoscopy data reveal no organic changes. So we are talking about a functional disorder in this particular patient. Irrespective of what is written, most of the time when you think that this is a disorder in the colon, according to the regions that have been mentioned, you think of irritable bowel syndrome. It is a functional disorder. We have here just a very straightforward question. Who do you think needs primary prophylaxis of iron? A pregnant woman. That is 2-in-1 woman. So it's the first is the best possible answer to choose for a pregnant woman. Next, we have history of a patient with unstable angina pectoris. First of all, you are going to try conservative treatment, and then when your conservative treatment is not working, like we have anticoagulants, nitrates, alpha adrenal blockers, you want to know what is happening. Maybe there is an obstruction at the level of the coronary arteries and so on. So the best thing to do is coronarography. If you try stress tests or physical exercises, you might have a very, very bad outcome, knowing already that the patient have angina pectoris. So we have a 28-year-old woman here with irregular casual sexual life. So all these other symptoms mentioned there, they are not the one raising the red flags. Is this irregular casual sexual life? And what you are thinking of is that maybe the patient is having HIV or syphilis. But RWE means Wassermann reaction, and it's negative, meaning it's not syphilis. So what examination must be done first, knowing that this patient is also a drug user, and these are not signs of hepatitis actually. So we are thinking of HIV. Always think of HIV, hepatitis, syphilis in patients that have casual sexual life. So the last question for this very first video, before other series of videos that will be coming up on this YouTube channel. A 35-year-old woman was admitted to thoracic surgery department. So you notice this fever is quite hectic, 40, and there's something about the cough that the woman is having is purulent sputum with blood and bad smell. So this is definitely something that is causing like a disintegrating process in the lungs. So you want to narrow your answer down to tuberculosis, to abscess of the lung, probably also to bronchiectatic disease, because it predisposes the lungs to different infection. But many times they will give us some other interesting history in bronchiectatic disease like cystic fibrosis and so on. But look at this temperature very well, 40 degrees centigrade. That is very common for abscesses. So you can have a sputum and blood. You can have more of blood in bronchiectasis disease, and in pulmonary tuberculosis there should be one or two more interesting history, and the temperature is not usually up to 40. So abscess of the lung. Thank you very much.